This is Yeah, We're Going There with Dr. Natalie, breaking the silence on pelvic health for women and men. Yeah, we're going there because knowledge drives better health. Before we get started, just a quick disclaimer. This podcast is for general educational purposes only and is not intended as medical advice. I'm not a licensed medical doctor, but a physical therapist, and I do not diagnose conditions or prescribe medications. Any decisions about hormone replacement therapy, vaginal estrogen, and other treatments should always be made in consultation with your own qualified healthcare provider. So, let's start with the basics. What are hormones? Hormones are chemical messengers produced by glands in our bodies that regulate and coordinate numerous bodily functions by sending signals to organs and tissues throughout our bodies. Our bodies produce so many hormones, but our focus today will be on estrogen and progesterone, which are primarily produced in the ovaries, and testosterone, which is mainly produced in the ovaries and adrenal glands in women. Glands are specialized organs in the body that produce and release substances, such as hormones, enzymes, and other secretions, vital for regulating bodily functions. Young kids have these hormones, but in much smaller amounts. During puberty, estrogen, progesterone, and testosterone levels increased. Ideally, young women will experience a regular 28-day menstrual cycle, but as we know, not all do. When your period starts, estrogen levels are low, typically anywhere from 20 to 80 picograms per milliliter, but they increase when bleeding stops and peak at ovulation, where it's at about 200 to 500 picograms per milliliter. During ovulation, an egg is released, and its shell makes progesterone. If the egg doesn't fertilize, the progesterone drops, causing your lining to shed, and you get your period again. A pregnant woman's estrogen can go as high as 5,000 picograms per milliliter. But as soon as she delivers her baby, it drops below 20, which is the same number seen in postmenopausal women. And it may not normalize again until after she's done breastfeeding, if she does breastfeed. The reason this happens is because now the body needs to focus on producing prolactin hormone for milk production, and estrogen takes a back seat. So technically, a nursing woman can be considered to be in menopause that whole time. That is literally the definition of menopause, a pause in the menstrual cycle. And just like women in menopause, these postpartum women can experience the same things as postmenopausal women, such as hot flashes, night sweats, brain fog, vaginal symptoms, including dryness, leakage, and so forth. At around 35 years old, our testosterone begins to drop. And if you've been on oral birth control pills or spironolactone for acne, your hormones get even more messed up. A decrease in testosterone levels contributes to low libido, increased urinary tract infections, and pain with intercourse. And we often consider this period of time called perimenopause. Perimenopause can start years before menopause. And during this time, most women will experience irregular menstrual cycles. When menopause does happen, all these hormones drop closer to zero. Menopause is the day on which you have not had a menstrual cycle for 12 months. Any time after that is considered postmenopause. And because organs throughout our body have hormone receptors that crave estrogen, testosterone, and so forth, they will be hugely affected by the low number of hormones in our body. This is what we experience as symptoms of menopause. And there's so many symptoms of menopause. Symptoms include hot flashes, night sweats, recurrent urinary tract infections, acne, fatigue, thinning hair, brain fog, sleep disturbances, weight gain, urinary urgency, frequency and leakage, heart palpitations, osteoporosis, irritability, anxiety, and depression. Sounds terrible. And there are more. Every organ that relies on these hormones, such as our bones, brain, vaginal tissue, to name a few, will all be affected. Any hormonal fluctuation can lead to what we call genitourinary syndrome of menopause, or for short, GSM, which includes vaginal dryness and irritation, itching, burning, frequent urination, light bleeding, pain with intercourse, and increased incidence of urinary tract infections or UTIs, all because of a drop in estrogen. Again, I said any hormone fluctuation can cause these symptoms. So, lactating or nursing women can experience any of these symptoms because remember, after delivery and while nursing, their estrogen levels drop super low. Also, women who are on aromatase inhibitors or selective estrogen receptor modulators or SERMs, like tamoxifen for cancer therapy, or who have undergone an oophorectomy or hysterectomy, where their ovaries are removed, can experience these symptoms because of the reduction in estrogen. Remember, estrogen is mainly produced in the ovaries. This can affect younger women who are on oral birth control because oral birth control suppresses estrogen production. So, what are our options in terms of treatment? For genitourinary syndrome of menopause, it's so much simpler. Anyone suffering from those symptoms can ask their medical doctors for a prescription of low-dose vaginal estrogen, which comes in the form of a cream, a suppository, or a ring. I personally prefer the cream because you could apply it where you need it. Low-dose vaginal estrogen is different than what we call full-body hormone replacement therapy, which is systemic and affects the full body. Low-dose vaginal estrogen is local and only addresses the needs of the vaginal tissue and urethra. It helps with dryness and lubrication. It prevents tissue atrophy or shrinkage. And it helps maintain the correct pH levels in the vaginal microbiome, preventing urinary tract infections. Vaginas are an acidic environment, but without estrogen, they become more basic, if you remember your chemistry, making you more prone to infection. Vaginal estrogen also helps plump up the tissue around the urethra, helping reduce urinary urgency and frequency and even leakage, and can help reduce pain with intercourse. It actually can save lives by preventing urinary tract infections. Globally, urinary tract infections contribute to 230,000 deaths each year. Women whose menstrual cycles return, for example, when they're done nursing, can stop applying vaginal estrogen when the symptoms go away. But postmenopausal women who will never menstruate again because they don't produce estrogen will need to continue to use low-dose vaginal estrogen indefinitely. I tell my patients, if you don't brush your teeth will rot. And similarly, if you don't continually use estrogen, the tissue down there will shrivel up. If you don't use it, you'll lose it. Low-dose vaginal estrogen is typically used twice weekly, before bed, after the last time you pee for the night, and it takes 2 to 3 months to reach maximum effect. It is completely safe. Studies have shown that it is safe even for nursing women to use, and it doesn't affect their milk supply. There's some well-known urologists who state that even women who have had or currently have breast cancer can continue to safely use low-dose vaginal estrogen. And that there is even a study that was recently performed on women with breast cancer, which states that the women who used vaginal estrogen died less. It improves their quality of life. But again, this is a discussion to have with your medical doctor. The other menopausal symptoms that affect our whole body can be treated with what is typically known as hormone replacement therapy, or HRT, also known as full body treatment by either a patch, a cream, or oral medication. And every woman who goes on HRT, if they still have their uterus, need to also be prescribed progesterone, which protects the uterus. If they've undergone a hysterectomy, then they don't need the progesterone. Some physicians believe that even if you are on hormone replacement therapy for full body postmenopausal symptoms, you still need to be screened for genitourinary syndrome of menopause. Often, the estrogen patch that is prescribed as hormone replacement therapy will not provide enough estrogen to affect the vaginal tissue. And many women will need both hormone replacement therapy and vaginal estrogen. Vaginal estrogen is a microdose of estrogen and will not affect the whole body treatment or hormone replacement therapy. Again, low-dose vaginal estrogen comes in different forms, such as a cream called estradiol, which comes with an applicator, but you could use your finger to rub it in. Or, for those of you who feel it's too messy, they could use vaginal estrogen in the form of a suppository that also is inserted with an applicator. Lastly, there is a ring called the E-string, which is typically prescribed to people with dexterity issues or even those with dementia, but they do need to see their physician every 3 months to have it changed. Recent studies have shown that vaginal estrogen reduces the risk of urinary tract infections by 50%. That's a huge number. So, we now know that low-dose vaginal estrogen treats urinary and vaginal issues. Let's discuss hormone replacement therapy a little bit more. Hormone replacement therapy are full-body hormones, including one, whole-body estrogen, which is a higher dose of estrogen than is used vaginally, and it treats osteoporosis, hot flashes, and night sweats. Number 2, whole-body progesterone, which must be taken if you have a uterus when taking whole-body estrogen to protect the uterus from cancer from the increase in estrogen. It also helps with mood and sleep and can even be given to women without a uterus for those conditions. Number 3, whole-body testosterone is not just for men. Interestingly, though, in women, testosterone starts to drop while we're in our 30s and drops to 0 after menopause. We need testosterone for sexual function, but also for bone and muscle health and for mood regulation. But it's not FDA approved for use in women in the US. Medical doctors are working on changing this, but in the meantime, whole-body testosterone can be prescribed off-label for women for low sexual desire that causes distress. It is 1/10 the dose of what is prescribed to men, and it's not covered by insurance. It helps with libido, arousal, and lubrication, and even helps with urinary issues, since there are testosterone receptors around the bladder and urethra. It will often take 4 months of use, though, to see improvement. Similar to whole-body estrogen, whole-body testosterone is not enough to treat vaginal issues. You may think, why does that matter? We already have vaginal estrogen. Well, interestingly, we actually have testosterone receptors in the vagina. If women need something to affect the testosterone receptors vaginally, that can often be addressed with vaginal DHEA. But it's a prescription. DHEA is a precursor to both estrogen and testosterone. Some people need both vaginal estrogen and vaginal DHEA. The problem is, at this time, vaginal DHEA is still very expensive. So often women will start with vaginal estrogen, which is just cheaper. Actually, without insurance, it potentially can only cost $13 per tube for vaginal estrogen, and that could last 2 months. The sad thing is that the last few decades, women were scared away from hormone replacement therapy and its benefits. And many women continue to believe that hormone replacement therapy isn't safe. This all stems from a large study in 2002 called the Women's Health Initiative, which found that a common form of hormone replacement therapy, specifically synthetic conjugated equine estrogen, also known as Premarin, plus synthetic medroxyprogesterone acetate, both of which are not typically used as first choice of treatment, raise the risk of breast cancer, heart disease, stroke, and blood clots. So doctors stopped using it for disease prevention, and many women quit treatment. Unfortunately, this has had a major, even harmful effect on women's health and quality of life, because millions of women were left with severe menopausal symptoms that interfered with work, relationships, and daily life. And some lost the bone-protecting benefit of hormones and faced higher fracture risk. Since then, researchers have shown that risks vary by the type of hormone, how it's given, a woman's age, and how soon after menopause she starts taking it. And today, most experts say women should not automatically fear hormone replacement therapy. Starting near menopause, typically under the age of 60 or within 10 years of going into menopause, and using the lowest effective dose, choosing safer options for individual risk, like estrogen alone if a woman has no uterus, or transdermal patches, which means through the skin, instead of oral estrogen, to lower the clot risk. And of course, regular monitoring makes hormone replacement therapy a safe and effective choice for many women who have troublesome symptoms. Women should feel reassured that when monitored carefully by their clinician, hormone replacement therapy can be safe and highly beneficial, rather than something to avoid automatically. In fact, the Women's Health Initiative now acknowledges the conjugated equine estrogen alone reduced the risk of breast cancer by 23% and reduced breast cancer death by 40%. Also, bioidentical hormones like estradiol and micronized progesterone are chemically identical to human hormones, making them potentially safer with fewer side effects compared to synthetic hormones. All this emphasizes how treatment with hormone replacement therapy must be tailored to the individual, as no two people have the same symptoms or the same chemistry. It is generally considered safe, but like any medication, there are things a doctor needs to consider when prescribing it. According to randomized control trials, the optimal time to begin hormone replacement therapy is within 10 years of menopause onset or before the age of 60. It could even be given during perimenopause to manage hot flashes and night sweats. When started before the age of 60 or near the onset of menopause, hormone replacement therapy significantly reduces all-cause mortality and cardiovascular disease. So you may be wondering, what are the risks of starting hormone replacement therapy more than 10 years after the start of menopause or the age of 60? There is a risk of exacerbating an underlying cardiovascular condition. So the prescribing physician must do a full cardiac workup on that patient. Again, this demonstrates the importance of individualized care. Another consideration is how hormone replacement therapy is being delivered. For example, transdermal or through the skin, with patches, gels, or creams are preferred over oral administration when someone needs full body estrogen and they're at increased risk of blood clots or they have high blood pressure. When it's delivered through the skin, it doesn't carry the same risk. Also, as I mentioned earlier, women who still have their uterus must also be prescribed progesterone to prevent endometrial cancer. Women with a history of breast cancer will also want to discuss the benefit versus risk with their doctor, as this definitely needs to be considered. It's important to remember that one size does not fit all. So talk to your physician about your symptoms and risks so that they can tailor your treatment specifically to you. What it all really comes down to is quality of life and making the best of the years you have left. I hope you found this podcast insightful, educational, and helpful. If you did, I hope you will share it with all the women in your life. Until next time. Thank you for listening to Yeah, We're Going There with Dr. Natalie. If this conversation helped you feel more informed or less alone, consider subscribing, leaving a review, or sharing the episode. Until next time, yeah, we're going there because knowledge drives better health.